no, I can't read this handwriting.
As 1,000 milligrams of acetaminophen orally, 4 milligrams of denditron under the tongue, and trial of clear fluids.
Seriously? It says all that?
It's not in the text with the emojis. You kids can't read for shit.
Welcome to the Pitt podcast, the official companion to the Pitt on HBO Max. I'm Hunter Harris.
And I'm Dr. Alok Patel. 4 p.m. in the Pitt, that's episode 10. We're going to talk to one of the show's writers, Simran Baidwan, and the director of this episode, Damian Marcano.
We are all trying to find the truth in the scene. We're not trying to overact. No one's trying to get that special shot and whipping the glasses off and saying that, prolific thing. We're just trying to say, if these doctors are working as a team in order to create these miracles, then I think we have to fashion ourselves in the same way.
And then we'll go outside the Pitt and talk to Dr. Gita Pensa, a medical malpractice expert who consulted on the season.
Nobody wants to have anything bad happen to any of their patients. And inevitably, sometimes things do. And when you are a steward for that person's life, you take that responsibility very, very heavily.
Just saying medical malpractice gives me hypertension. Today's shift starts now. 4 p.m. is not everyone's finest hour, for better or worse. Like, it seems like no one in this episode is having a good time. Everyone is at a boiling point. But what are the moments that stand out to you, Hunter?
Here's what I can't stop thinking about. The scene of Robbie and Dr. Mohan, because he totally loses his temper with her in a way that I'm like, I don't think we've ever seen him this curt, this short, this almost cruel when he realizes Dr. Mohan is actually having a panic attack and not having a heart attack as she thought.
I had it all planned out, and now everything's just out the window.
Wait a minute. Is this a panic attack because of your mommy issues?
What? No.
Jesus. Do you need to go home? You should go home.
No, I'm fine.
I don't need the fucking liability. Go home. And the rest of you, the last time I checked, the ED is a shit show, so let's all get back to work, huh?
The moment he realizes when he flips a switch, he goes from being concerned about a heart attack and he's like, is this about your mommy issues? I was like, damn it, I'm not happy with Dr. Robbie right now.
But the way that he almost is so dismissive and he's like, go home. I was like, oh my gosh. It's like giving Housewives his reaction. It's so over the top. I did not appreciate that. But I think this is the first time that we've really seen him be actively cruel in a way that's something is going on with him. He's very, I don't know, very dark.
He also, I think there's maybe a little bit of the generational thing. He might come from a generation where any type of mental health issue or struggle was seen as weakness, which just added to stigma, people not wanting to open up about it. So I do like that Dr. Al-Hashmi, you immediately seen that scene. Her eyes are kind of like, bro, what are you doing? And then later on, she pulls him aside and she's like, don't be a dick.
Yeah.
And I think it was a realistic scene. I bet there's people out there in healthcare who are afraid of saying I'm having a hard time or acknowledging it's a panic attack. But the setup to her panic attack was real.
Okay.
She was
I want to talk about that because in my head, as someone who's had panic attacks, I'm like, wouldn't you know? You're a doctor. Why would you think it's a heart attack?
My instinct tells me she has never been in that position before. She's sweating, her heart's racing. She just doesn't know. I don't know. She doesn't know.
I'm like, sister, you're a doctor. Come on. But I wondered though, do you think Dr. Robbie is harder on Dr. Mohan than other doctors? Because last season he was calling her slow-mo. She's like, well, I have the highest patient satisfaction rating, whatever. But then this episode, we really see her lose her temper. Everyone's losing their temper with everyone.
That's a good take. I feel like she recovered from the slow-mo stereotype he gave her in the first season. And he came around and he started to really appreciate her approach.
Yeah.
And, Dr. Al-Hashmi came in, really appreciated Dr. Mohan's work as well. And I think to your point, I think it's just the moment, the fact that Dr. Robbie is checked out, you got this code black happening, all this is going on. And he's like, I cannot lose one of my physicians. And I think the mental switch he had from, oh my gosh, this is a cardiac issue, to damn it, I need you in the ER, be stronger or go home. I think he just had this moment. But I'm glad that he came back around later and was like, oh my gosh, that was wrong. I
don't think he's like, oh my gosh, that was wrong. He's like, hey, it's very deadbeat dad. Hey, sorry. Let's get back to work.
You're giving me the deadbeat dad card. Okay.
Yeah, because there's something different about the way that he treats Whitaker and Javadi, which feels a lot like Whitaker feels very like friend, like Langdon replacement. Javadi feels very paternal, which I like because he's very like defensive of her to her mom. But then with Dr. Mohan, I don't know. He's very harsh, but maybe that's because he knows she's like a really good doctor.
Yeah, maybe he's holding her to a higher standard,
Yeah.
similar to probably what is going on with Langdon.
Well,
He's obviously hard on Langdon.
he
and
doesn't
holds
want
him
to
to
talk to Langdon.
Yeah, it's like a weird level.
Yeah.
That's like angry, toxic, you hurt me, father. Like re-enter my. That's a whole other category.
Yes, he feels very betrayed by Langdon. I know Ogleby gets a bad rap, but this episode, I'm like, kind of, you deserve it. Like, what do you, when he's on the like helicopter pad talking to Dr. Robbie, Dr. Robbie's like, you know, how's your first day going? Checking in. And Ogleby is like,
I think we have a very different idea of normal.
Not for everyone.
I'm not sure it's healthy for anybody.
Here's your leg.
Jesus.
I love that ends with like him being like a leg being placed in his hands and him like not knowing what to do. I love seeing Ogleby uncomfortable like that because it's like, you don't know everything and maybe you should get checked a little bit. What did you think of that?
This happens to fourth year med students all the time who have spent 3 years studying the textbook and they think they know everything and maybe they do really well on their tests and their boards and then they go into an actual clinical scenario thinking they're hot shit. And after a few hours, like they're like, oh my gosh, and they get humbled by actual experience and by the spontaneity and the craziness.
Yeah.
I think this is a good turning point. So I said earlier that no one was having a good time in this episode, but this might wind up being a good pivotal moment for Ogleby.
With Ogleby, I mean, he is just such a jerk sometimes and so obnoxious that I'm like, how is Ogleby kind of like playing the know-it-all with the other students? I mean, he's so mean to like Javadi about the Dr. J stuff this episode. But then did you notice that when he sees the English teacher, he like checks it on him, that's his patient, and he gives him a copy of a book that he's reading and it's James Baldwin, Notes of a Native Son. I'm like, okay, sorry, hold on. How do you have so much, like, how are you reading Baldwin? Like, you're obviously very educated, but then also have no empathy for, like, the plus-sized patient, for the woman who's, like, he's like, give her more ketamine. Like, we can't deal with her right now. Like, I don't know. I didn't like that.
I think that's a big part also of these clinical rotations for students and is learning those interpersonal skills. And we see kind of a trace of this with Santos and Garcia when she's like, clearly we need to work on a decorum for R2s.
Oh, my
So it goes
God.
back again to appropriate behavior and speaking. And like you learn. So Ogleby, like, I think he's going to emerge. I think he's going to emerge from this and be like, all right, a little bit of humility is needed. The orthopedic surgeon rolls in, Park the Shark. And he like
Okay.
also tells Ogleby in so few words to zip it.
Not even, okay. Park is an orthopedic surgeon, you
He's
said?
an orthopedic surgeon.
Everything about him, love. Spinoff now.
Oh.
Obsessed with him.
You
Obsessed
like
with
this
him.
dude.
Oh my God, of course. Are you kidding? He's a diva deluxe. The way he walks into the trauma room and he's like, doesn't even say hi to anyone.
Park the Shark, orthopedic surgeon.
Is this a favorable amputation?
Pretty clean cut. Fence sliced through like a guillotine.
X-ray? Not too bad.
Just tying off a couple materials. I'm not blind.
Just walks in, laser focus, picks up the leg. He's like talking to himself in a way that I loved. And then, I mean, poor Whitaker, whenever he's like, yeah, you need to like do like 3 rinses or whatever. And Whitaker's like, of saline? He's like, yeah, duh. I'm obsessed. Sorry.
You know what's funny? I think they were trying to portray the typical arrogant, toxic surgeon who might be really great at their job, but is just not nice to people.
Yeah.
And in your eyes, he's a deluxe diva.
Absolutely. No, that's the man I want operating on me. I'm like,
deluxe
you
diva.
don't have to be nice. Just like get the job done. Get my leg reattached.
Did his hairstyle fit the deluxe diva? Like the
Of
slick back?
course. And no, his name is Shark. He literally, I like heard the Jaws theme as he walks into the OR. Like seeing him in profile was incredible.
This take is so good. Park the Shark. Imagine if there was the real life Park the Shark. If you're like, hey man, you're a deluxe diva. I don't know what he would throw at you.
I would hope he would say thank you.
And then walk back out.
I need like a group chat of the Shark, Abbott, and Garcia. Like I need those 3 in a room together because like their energy is incredible.
Oh yeah. I wonder who would out alpha whom in that trio. I think Garcia is the alpha of both of them. I don't think she backs down from anyone.
Okay, and speaking of Garcia being the alpha, I want to know if you clocked how Garcia is very rude to Dr. Al-Hashmi when they're doing the slash trach.
Mm-hmm.
Because it's like incredible Dr. Al-Hashmi pulled this off, that she directed everyone through it. And then Garcia's like, wow, like, what'd you do? Like, now we're about to go back in the OR. Like, we'll have to clean up your mess, whatever. And Dr. Al-Hashmi is like, or they'll be happy that I saved this kid's life. And then it's Dr. Garcia who was like checking Santos about being rude to Dr. Langdon.
I've been a goddamn pariah for the last 10 months for doing the right thing. Or maybe you're a pariah because you don't play well with others. If you've still got beef with Langdon, go tell him. He's here to stay, so put on your big girl panties and work it out. No. You want to have sex and eat ramen in bed, I'm your girl. But if you want to talk about this Langdon shit again, call a therapist.
What do you think about a 2-woman Broadway show called Sex and Ramen in Bed, starring Garcia and Santos? Would it do well?
I don't like eating in bed. I don't like eating in bed culture. I don't know. It's a little bit gross to me. No. Okay, but we have confirmation now. I think we kind of had confirmation a little bit earlier that because of the toothbrush thing, but now we know for sure.
That was when it was like hinted, and people were like, all right, cool.
Yes, now we know for sure that Santos and Garcia have a little situationship. And I don't know. I think I like that Garcia is willing to check Santos. Like, she's so able to compartmentalize.
The hierarchy and the egos in medicine do exist, and the inter-hospital situationships that happen. It's like, I'm not gonna say this from personal experience, okay? This is professional setting, because I would like to say I don't have a huge ego in that setting, but I've heard from people who have dated superiors or they've dated medical students, and like that stuff happens when they're like, wait a minute, I'm your supervisor, but I'm also sleeping with you. Like, this is again why this is not appropriate and should be handled very carefully. And so I think this little scenario that we're seeing, it's kind of a relatable one.
Yeah, but I'm glad that Dr. Garcia was like, the reason why people don't like you in the ED is because of your behavior, not because of like the Langdon golden boy. Because Langdon wasn't like that popular. He was obviously one of Robbie's favorites, but like everyone else was kind of like rolling their eyes at him too. Like, last season, the previous day that we've seen. Like, he's not beloved by every single person.
We just need to see that Santos Langdon conversation. We just need to see the two of them finally sit down. Maybe it's in the break room and just hash it out.
Yeah, there's some healing that needs to happen. We need to take it to the red table. But do you think that Santos does not like being taught?
100%.
Yeah.
I don't think she likes being taught. I don't think she likes being told what to do.
Yeah, definitely not corrected.
She's got that Sonya Blade Mortal Kombat vibe where she's like, I'm in charge. I don't need anyone's help.
Yes.
I got to say real quick, we're talking about like the tension of the room. I love the subtle line when I think Santos says something along like there is no tension, and she's referring to the chest, the pulmonary cavity. And Garcia's like, at least not a pneumo, because she's referring to the two of them have tension.
Wait, I did not even clock.
It's like this really subtle little line.
Okay, but tell me, who was more, I guess, can you explain to me like the differences and maybe what they were thinking between Santos and Langdon? I couldn't really understand like how their approaches were different and why his was better than hers.
What they're essentially first kind of talking about is there's blood around this patient's lung, a pneumothorax. So the first kind of situation that they are disagreeing upon is whether or not they need to drain the blood from the chest. Santa's like, there's blood, we got to drain it. And Langdon is like, the patient's stable. You don't need to drain it unless it's a certain size. And then Dr. Al-Hashmi is like, yeah, we can wait before we drain the blood. Then the second scenario is how to get the air out of this patient's chest. When she's like, we need a chest tube and we need to drain it. And he's like, you can use this thing called a Thoravent. And that way, you can keep it in there for a longer period of time. You can suck out the air. And it's this good teachable moment because Langdon has gone through more of these procedures than she has.
Yeah.
And he's not being mean. He's like, listen, like you don't need to do more to the patient and just listen for a second.
Yeah, like something more invasive versus less invasive.
Yeah, more or less.
Okay.
Now it's a tactile procedure. 2-centimeter incision through the tracheal rings, finger in the trachea. Bougie into the airway. Thoughts on what's next, Dr. Whitaker?
Insert the ET tube into the trachea.
Suction. Lots of blood in the airway.
So like, this is pretty complicated. I talked to an ER doctor, a trauma surgeon, and a pediatric surgeon just casually about this procedure. And so essentially, you got to create an airway. You either can't intubate someone or you can't oxygenate them through their mouth. And perhaps there's an upper airway obstruction, there's trauma, there's some reasons you need to go in through their throat. And in certain situations in kids, it's actually better in an emergency to do a slash. So basically a vertical incision. The more permanent solution, or I should say like the more controlled solution, would be a horizontal traditional surgical tracheostomy, which is why Langdon makes that comment. Like, this is going to take 20 minutes.
Yeah.
So she's like, it's emergency time. And so people may have heard that term crike, where you like go, that's a little bit higher, where you're going to create that airway, and you might not be able to do it in kids. So long story short, because of the situation and it's an emergency and the anatomy, the unique anatomy of kids, that's why Dr. Al-Hashmi is like, we got to go vertical. This is an emergency. So they just call it a slash. So there's a lot happening, but shout out to the medical writing, because like I fact checked this and I was reading some journals from emergency medicine journals, and it's totally accurate how she describes it, handles herself under pressure. And even Dr. Robbie is like, damn. The one thing, there is something unrealistic though.
Okay.
When Garcia walks in and she's annoyed,
yeah,
I did not hear that. I have not seen that. I don't think that would actually happen. I think a surgeon would come down and understand, like, okay, this is a kid.
Yeah.
This was an emergency. What matters is that the kid's life is saved.
Mm-hmm.
And it's pretty common knowledge in the ER, in trauma worlds, that if you get an emergency airway, that it can be repaired and stabilized in the OR. That's why Dr. Al-Hashmi is like, yeah, they'll fix it in the OR, but patient is alive. That's what matters.
Right. I mean, Dr. Al-Hashmi kind of like rolling her eyes as she's walking out, like, loved it. Couldn't get enough of it.
Yeah.
I do like how it's like Dr. Al-Hashmi checks Dr. Garcia checks Dr. Santos, and then like Dr. Raul won't even talk to Dr. Langdon.
And Park the Shark checked everyone.
Yeah.
Like there's a lot of just checks in this episode.
Because everyone's like at the end of their row. But that was like a very cool scene to see. But then I'm also like, wait, they just put their fingers in a child's like throat.
I will say in med school, I did several months of rotations in surgery. That's what I thought I was going to do before pediatrics. And tracheostomies are like my favorite thing to do.
Oh,
in
wow.
the majority of the situation, they are controlled surgical tracheostomies in the OR.
Okay.
And oftentimes it's somebody, for whatever reason, needs a long-term breathing tube.
Mm-hmm.
And a tracheostomy is, in most cases, and if not all cases, the safer, more comfortable way to do that.
Okay.
And they're very satisfying to place surgically. It kind of just like pops in and you like sew it down. Anyway.
What's your name?
My leg hurts really bad. Did I break it?
I wouldn't say that it's broken exactly.
We're gonna get an x-ray to determine that. Put that on the gurney, line it up for x-ray, keep your fucking mouth shut.
Okay, Alok, we need to get specific. Like, what is happening with the leg? And like, what does a surgeon in this case look for that it can be reattached or that it can't be reattached? I want to get into the medical stuff.
Yeah, there's so much happening in this short, dramatic scene. I mean, obviously you got Ogleby like shaking with the leg, but the first thing I noticed is the leg was wrapped and presumably stored appropriately.
Okay.
Everything is clean. You want to keep the limb slightly cold, but not frozen, which could kill some of the tissue, but it's like clean. It's in a waterproof bag. I don't know why he's unwrapping it just yet, because no one's told him to unwrap it. But
I mean, he's also about to tell this woman that she doesn't have a broken neck or something. It's like, you don't know that.
Now, what's interesting is like you could lose your leg, but because of being in shock and a ton of adrenaline, you may not feel it right away. But you've cut nerves in half, so you're gonna feel it.
Yeah.
Then you're gonna start going into panic. You hear Donnie mention that she's gotten some fentanyl for pain. Then, they want to give her some ketamine, which is another, you can preserve someone's blood pressure while also handling pain.
They take ketamine all the time on this show.
Yeah,
it's like Bushwick.
Yeah, it's like Bushwick. It's used often in ERs. And then Whitaker mentions the popliteal nerve block, so like regionally blocking all the sensation going downward on that leg.
Okay.
Just to keep her as comfortable as possible. And then when your deluxe diva, as you call him, Park the Shark, rolls in, what I'm guessing he's looking at in this brief moment is looking how clean the separation is on the limb.
Okay.
And he's looking at the limb and he's presumably looking at the vessels, the bone, et cetera. Like, can I reattach this in the OR? Because you don't want to have a poorly reattached limb that may not take or cause an infection. So I think based on Park the Shark's experience, he's like, okay, we can give this a go.
It's not about us, it's about them. She's so calm. She had a long time to prepare for this moment. What she's doing for her sons, managing this with so much grace. The real gift of love. I feel like an asshole. All they want is more time with their mother. All I want is less time with mine.
We've just experienced This moment with Roxy, and as we talked about with Justin Baker, kind of a hallmark example of the doctrine of double effect. And, McKay explained to her, like, we're going to give you more pain medications that may slow your breathing. Clearly, as mentioned, Roxy's like thought through this. The family's there, husband's supportive. He's like, this is where I need to be. Like, they know what's happening. I was reading journals about how often palliative care happens in the emergency department. And it's interesting, like, there's statistics about how many times people go to ERs in their last months of living because they're in pain, they have chronic illness, whatever it may be. So I do think that the conversation is happening more in ERs as people need to find a way to really preserve their quality of life.
Yeah.
The one thing that I think is so real is having to compartmentalize your feelings and go from patient to patient. And Jafadi has that moment where she steps out, but I'm just gonna say it's okay to cry in front of a patient or like be pissed or swear or be human. And the few times like I've had emotional moments in front of patients in whatever way, like it makes you more real, it makes you human. I've seen experienced surgeons get teary-eyed in front of families just because you're all going through this together. Hunter, as we talk to Simran and Damian, what are you most curious to know about how this episode was written and created?
I want to know all about the Santos Garcia situationship. How this happened, how like kind of the slow rollout of this. Like we've gotten ideas, like hints that maybe they're together or like together-ish. But I don't know. I want to know everything about kind of tracking that throughout the season.
I'm right there with you. So let's get into it and ask all the questions to show writer Simran Baidwan and the director of this episode, Damian Marcano. Simran, I have to ask you this question. In this episode, it feels like we are reaching a boiling point with so many character and social situations. So I have to ask you, what was it like to kind of shepherd all the characters to this point without giving too much away too early?
We really have to structure the seasons into like a trifold with 15 episodes. So we try to have things, in the first 5 episodes that there's something that incites us to propel us forward into the middle, 5. And now with episode 10, it's really heading, we're just freight training it, no breaks to the finale. So, we're really trying to make a concerted effort to yes, the cases are there, but what does that mean to our characters? And how are we also in the fact that we're, 1 hour, per in one shift, that they've been on shift for 10 hours. People are exhausted, mentally, physically, all the other things that you've been trying to avoid for the day keep crashing back at you. So it's, it's very purposefully constructed to start hitting ahead.
We can feel that. The freight train, it's on its way. Damian, I want to ask you, you directed a few episodes in season 1. What was it like coming into season 2? What was different? What caught you by surprise?
I would say every episode of The Pitt is a surprise, right? It's fun even for, I think, us as the directors to kind of find out what's happening or what's coming, because we are all a very close-knit and close working group of people. So being at The Pitt, you run into the writers, you run into Scott, and I'm sure everybody always wants to know, so what do you guys got planned for us? And with season 1, we had this larger than life mass casualty, for 12 and 13. And maybe I thought maybe that would become our show's format and they would kind of do the same thing again. But I remember when I saw Scott and Simran early on, and they just kind of had these smiles about what they had planned for us for this year. And I was actually, without giving too much away, I was just kind of glad to see that we didn't repeat just the same thing from season 1. The characters are the same. There's new faces as well, but there is some new exciting life. And I would say that is what surprised me the most about The Pitt. I'm in awe of what our writers do. And the fact that they were able to put these new characters into our season and to feel as if, I think they were there season 1, right? But no, they weren't. These are all new faces. And each one of our cast is just, it's like a dial off of each other, but they're all just so specifically different and unique in their own way. And it's so refreshing when you are directing an ensemble like that to be able to have, just that many colors to work with, man.
Simran, I want to kind of dig into this dynamic that we see in this episode between Langdon, Santos, and Garcia. this Santos Garcia sort of like simmering, are they together? Are they seeing each other? Has been like a really kind of fun, slow burn to like just deduce how well they really know each other. Can you tell us about tracking that and also what they see in each other?
I think it's like anything if you've ever dated somebody in the workplace, raising my hand, that you sometimes want to separate church and state, right? Like, yes, we met here and we like each other, but we each have jobs to do and we have things going on. And sometimes that kind of, inevitably comes to a head in that professional workspace. So yes, we always say that The Pit isn't a show that you should be folding your laundry. You should be paying attention because there are all these subtle context clues without having to say, hey, remember when we went out to, dinner last night? It's like, it's just part of what it is. But, I think it's also, we want to bring about what is that relationship? Is it just, a booty call kind of relationship? Is it something more? Does one person see it as something more and the other person's like, oh, I haven't really defined it. So we're just playing in that, in that pond of what it means, for Santos and what it means for Garcia. And we will have a little bit more of that clarity. You see already by the time you get to 10, Santos saying like, what are you doing? What are you doing after? And maybe like wanting to hang out more, and Garcia keeping it a little bit chill. But I think in this episode, I always said when we were on set to Damian and we were talking to our actors, like, this is not a scene between Garcia and Santos. This is a scene between Yolanda and Trinity, right? So think of that when we have that personal conversation later. It's not about doctor to doctor when we get towards the end of the episode. It's more about like, I see what's going on, but let me tell you to somebody who actually genuinely cares about you.
I like that there's a moment of Santos like complaining about how she's felt like a black sheep and a pariah for so long. And Garcia's like, well, but who's made you feel that way? Right? Like, I thought that was really interesting. Damian, can you tell us how you approached directing this episode?
I think like I do all of them, we just come to work, keep your head down. I say this because after directing so many things in our lovely Hollywood system, I think it is a very important ingredient to mention. Ever since we started this show, there was a little note from Noah Wiley in each of our binders, just kind of reminding everybody that we would put egos aside and we would come in here and we would try to recreate as best what this amazing medical community does, right? I step in like a lowly director in this scenario, right? I am at best trying to do what you didn't have takes or multiple opportunities to do on the day when you perform this life-saving miracle. So I attack every single scene of The Pit I do in that exact same way. We get together, we rehearse for, 15 minutes or so before we shoot one. And we more or less have a conversation, I think, in which we are all trying to find the truth in the scene. We're not trying to overact. No one's trying to get that special shot and whipping the glasses off and saying that, prolific thing. We're just trying to say, if these doctors are working as a team in order to create these miracles, then I think we have to fashion ourselves in the same way. And that's what we do time and time again.
I love how Damian is underselling what a vital component he is to the collaborative process of making this show a success.
Listen,
I think that was very poetic. That was very poetic. Wow.
I come from Trinidad, right? And my coat of arms, I keep I keep this on set with me every day. This is a $100 bill from Trinidad, right? And what it says on our coat of arms is, together we aspire, together we achieve. I've given one of these to Noah Wiley. I probably owe Simran a couple of these because it's just a little reminder I need every day to keep myself in check and to put myself in place in order for us as a team to achieve the greatness that we've just achieved. So I know that I'm an important part to the show, but I think one of my most important parts to the show is to sort of keep us on that path. I think if we continue to do the work that our writer's room is blessing us with amazing scripts, Simran is making me direct things that make me go 10-1 and leave the stage. Because I'm directing it and I'm crying and I'm like looking at this lady like, why are you doing this to us, right? But what I think we've seen now is however we happen to feel on set, seems to honestly translate through this negative that we are shooting and getting to this audience in exactly the way that we felt on the day. And I think it's also just sort of our, it's a vibes check, man. I'm a Rasta. I can't help it, man. We tend to talk about ourselves in very minimalistic ways while trying to do great things.
Simran, can you tell us a little bit more about how the two of you work together, like when you're on set and when you're talking about the episode?
Damian and I had the privilege of working together last year, and then he directed both of the episodes that I had this year. But instantly, I always call him my brother from another mother. We had this connection because, I'm Indian and that's my heritage, and Damian is Trinidadian, and there's a very large Indian population in Trinidad. And I think maybe just because we were both have this immigrant mentality. We come from different worlds. We see things in a different space. We really like the collaboration that television allows writers and directors to have, that we just gel and get it. And we can, because we get each other, can have really candid conversations, can have, disagreements that are obviously very, just cordial. They're not they're not adversarial, but we can really have in-depth conversations about the material and what the characters are going through. And, I think we just work together as we come together as a united front when we're on set and just, set a good vibe. Damian, the director, is always the one in charge on set, and Damian leads by example with his attitude and the way he wants to give the actors agency and the way everybody has a role. He, greeting everybody with a handshake or a hug. And, that tone really matters, especially when you're dealing with such serious subject, matters that we have on the show.
I had one last question for both of you. So my medical friends, anyone who works in the healthcare system, loves this show. Not surprising why. But one thing that does surprise all of them is that people who don't understand medical jargon, terminology, or really understand the procedures also love this show. Why do both of you think that is? Because it's true. People who don't know anything about healthcare still are captivated by the show. Why do both of you think that's the case?
I would say, from the mind of a director and that ingredient that we would put in, we have a lot of medicine on the show, obviously, and we have the doctors there that help us keep it 100% correct. But I'm always directing, looking for the interpersonal relationships during the medicine. But I think maybe for a while, medical dramas maybe haven't done enough of that with the doctors. You guys have always been sort of like in the OR, you're the doctor, and outside you're like the lover or the romantic or the divorcee or the whatnot. Our show, I think, kind of collides both worlds. And makes even those private moments where a couple like Garcia and Santos have to find a private moment. It's always something fun when we have one of those scenes to do. We're always trying to figure out, where are you going to go have this private chat? So I think that's the ingredient that we put in. From my own personal life and the things that I've heard, just like you've heard, I like to remind people that we've come out most recently of a time when all of these first responders pretty much saved all of our asses. Right. And we were at home and we all thought we were going to die. And we needed someone to shine some light on us, man. And they did. You guys saved us in that time. I think just like, one of my favorite reggae singers, Bob, would say, man, sometimes I spread so much sunshine on everybody, I forget I need a little ray for myself. I think our show is that little ray of sunshine back to you guys. So I am more than honored and more than thrilled to even be a part of something like this because, for once we've used some TV to really do some good here. And it's just an amazing pleasure.
I'd echo, Damian's sentiments. I think that's exactly it. I live in a multi-generational house. I have a 12-year-old, a 17-year-old, 50-somethings. I've got my parents chiming in from, they're in their 70s and 80s. And I think the reason why it hits so many different people and so many different things, because, clearly, we don't have any doctors in my family, much to my parents' chagrin. But, I think the reason why the 12-year-old gets it and the 80-year-old gets it is because there is so much humanity. There is so much heart. There is hopefulness, and you're seeing that. You're seeing that in the interactions. You're seeing that in the impact of these doctors and nurses. As much as they have to be stoic and do a job, they are also human. That's that's true resilience. That's, that deserves respect. And I think that, hopefully we are shining a light on that and giving them, healthcare workers their due.
Damn,
what
that was
wonderful
amazing.
answers. Incredible.
May this show run for 10 more seasons.
Your lips to God's ears. Thank you.
Thank you guys so much. Something that I did not realize is that Damian has directed so many episodes of The Pitt, that he directed stuff from season 1 and now in season 2. And I think that he knows the cast really well and knows like how everyone, what works best for every actor, which I think is always really interesting.
He probably knows how to, bring out different elements of them that they're going to appreciate.
Yeah.
It also speaks to his character that at the premiere, everyone was so happy to see him. I remember this because I remember being like, that must be Damian. I've seen pictures of him, but everyone was so excited when he was there, and there was like a different vibe around it. And I was like, oh yeah. I mean, Simran too. When they were around, everyone was so excited. I saw them both kind of joking with the cast and, dancing and everything like that. I'm like, all right, they clearly have a great relationship between the writers and the directors of the show and the actors.
But I think those two specifically seem to have a really good rapport. I think, Simran talking about being on set with Damian, I don't know. I think that they really like have a certain magic between the two of them.
We talked about Santos and Garcia and how this episode is really reaching a boiling point.
Mm-hmm.
And the other boiling point that's happening is with Mel and the malpractice issue. And again, in typical Pitt fashion, I love the fact that they brought in the real world experts to make sure that this was drafted in a realistic fashion. So that is why we've got medical malpractice expert, Dr. Gita Pensa, who consulted on the show this season to tell us more as we go outside the pit to talk about medical malpractice, which, oh my God, every doctor just loves talking about so much.
I feel like you're like you're tense.
Spill, girl.
Well, a couple of months ago, I got named in a malpractice lawsuit. And so today is the deposition.
That's it?
Dr. Gita Pensa, thank you so much for joining us today. Hunter and I have talked about this before, about how it's not totally uncommon for doctors to be sued or threatened with a lawsuit. Can you tell us a little bit more about that?
Oh, yeah, absolutely. So I come from this as a lens as a practicing emergency physician and also somebody who spends a lot of time in the medical malpractice world. And I work with doctors who have been sued and help them kind of get acclimated to the environment and then perform in that environment. Depending on whose numbers you look at, between a third and a half of all doctors in all specialties will be sued at some point during their careers. However, if you're in a higher risk specialty, such as emergency medicine, some are probably like top third. The really, really highest risk are fields like OBGYN, neurosurgery. A lot of the procedural specialties, the surgical specialties are way up there. And if you are, for instance, a practicing OBGYN, 90-something% of you are going to get sued. And even in emergency medicine, which is what we're really focused on here in this show, if you practice for 30 years as an ER doc, there's a 90% chance that you'll be named in a lawsuit at least once.
So the Pitt is known for highlighting issues that exist in the real medical community. What were your conversations like with the writers and with the executive producers about malpractice and how the Pitt could cover this subject?
I was so excited when I heard that they were going to go there. And I have to say, it was a virtual session over Zoom, and the whole writing room was there. And I didn't know enough about the show at the time to know that Noah Wiley was also one of the writers. And so when I got on the Zoom and I met all the writers and they tilted the camera towards him, I have to say, I'm not someone who's prone to being starstruck, but I think there was perhaps a little squeal of, oh my gosh. So it was very exciting. And then we really just got down to work and we had a really nuanced and, to my mind, just a really thorough discussion about the impact that medical malpractice litigation has on physicians who are named. But really, the conversations were around, what happens to the physician, what happens to their confidence, what happens to their sense of self, what kind of emotion are they experiencing. And it really does tend to be this really kind of toxic stew of shame, guilt, whether or not you were responsible for whatever the harm was that happened, whatever the adverse outcome that happened, whether or not you are responsible for that. there's always some sort of very difficult mix of emotions to contend with, because nobody wants to have anything bad happen to any of their patients. And inevitably, sometimes things do. And when you are a steward for that person's life, you take that responsibility very, very heavily. And there's always this sort of mix between responsibility and culpability, responsibility and blame, that it's a hard line to walk for a lot of us. And so we had a really wonderful conversation around all of those issues.
Can you maybe tell us about how the privacy of these cases, if I were being named in a malpractice suit, it's who can you even talk to about it on your team or on your staff? And how does that contribute to a culture of shame or just not feeling comfortable in that circumstance?
That's such a great question. And that's so much of what I work around. So historically, physicians really haven't talked about this, even though I just gave you those numbers and I said that, in a high-risk specialty like ours, we're practically all going to get named at some point. We don't talk about it. We don't talk about it because there's this perception that it's shameful and people don't know how to talk about it. And a lot of times you'll show up in someone's office the first day, you'll be in a claims person's office or a risk manager, or then maybe the attorney. And the first thing they'll say to you is, I know this is hard, but you're not allowed to talk about it. Now, I never want to talk about this without acknowledging the other side of the equation, that there are patients who have been harmed. Sometimes it is because of error. Many times it's not. Many times it's sort of a systemic problem, or it's, as we've seen on the show, you can get stuck between a rock and a hard place. And one doc can say we're going rock and the other one says we're going hard place. And one of those choices in retrospect may not have been the right choice. And we face these choices all the time in medicine. But then you have this outcome that none of us ever wanted. And we have our own feelings around that. And then you are blamed in a way. I mean, the process is really highly adversarial. And they'll come at you with all sorts of really, really harsh language and using words like, malpractice and negligence and malfeasance and just making you feel like just the worst possible human being. So this is actually a real threat to identity for us. But when you take a person who's dealing with all of that and you tell them now you're not allowed to talk to anybody, I mean, and we tend to be, except for Robbie, a lot of us are rule followers. You tell us not to talk about it, we're not going to talk about it. But it really does something to us. And I don't know really any other scenario in which you take an individual and you really truly traumatize them like this, and then the party line is you're not allowed to talk to anybody. And so part of what the work that we did together in the writer's room was I was so excited to see Robbie say this to Mel, to be able to draw that line between talking about and revealing important details of your case versus talking about the process is happening. This is how I feel about it. This is the ways in which this is really stressing me out. This is what I wish I could do. These things are not your case details. And we need, just as human beings doing really difficult work and being caught in a really tough position, we need to be able to talk to somebody who can receive it empathetically from us.
I wanted to ask you also, Gita, about any potential trends in malpractice cases that you may have seen over the years. I bring this up. It's I had a family threaten to sue me once because the MRI machine was down. This was not my fault. I did not break the MRI machine, but they were so frustrated with this delay in care because of that machine. Yeah. And what scares me is I can see some law firm being yeah, let's do it. Let's sue everyone at that hospital for millions of dollars. And so I'm curious if you've seen in your consulting work and your personal experience a trend. Are there, you mentioned some of the specialties who are more likely to be named in lawsuits. Is it always error? Is it, something you mentioned with systemic issues? Are more cases being dismissed? Is there any light you can shed about the direction we're going?
Sure. So there's a couple of trends that are interesting that we probably should unpack, but just sort of overall, of all these medical malpractice suits that are begun, probably half of them don't go anywhere. Half of them just eventually go away. There's really no fault that can be found. They can't really weave a story around it. They can't find an expert to support it. So there are a lot of medical malpractice suits that are initiated because something bad has happened or because a family is frustrated, or sometimes they can't get answers. They can't get answers from a hospital system that's very opaque, more and more corporate. It's really tough to get help or answers when something has gone wrong. And that frustration, where does it go if you can't get help from this side of things, right? Someone will tell you, go talk to an attorney, and the attorney is often more than happy to figure out, like, oh, like, is there a case here? Is there an expert who will support it? And it's like, I don't really fault anybody in this situation. I mean, like, patients, it's very frustrating to be a patient these days. So the more frustrated the public gets at the fragmentation of care, at the inaccessibility of care, and the harder it truly is to access care, the sicker people are when they get to care, the more likely there is going to be some outcome that nobody wanted, right? And then when the system, if they are being obstructionist, if it is a circle the wagon kind of mentality, which is not what I advocate for at all, but if it is that kind of mentality and the patient is really overly frustrated, they're going to take one of two avenues oftentimes. Either they'll file a board complaint, and we're seeing that really, like, so medical boards as an outlet for this, which control our licenses. And so we're seeing a big increase in medical board complaints, or they're going to file a lawsuit. And the plaintiff's attorneys they're going to go through them and see what seems like it has grounds or what doesn't. And the worse this is horrible, but the worse the outcome and the younger the patient, the more likely it is that they're going to try to pursue an action. Again, it's very complicated, very nuanced. There's pain on all sides. And the other trend that we're seeing is the rise in these so-called nuclear verdicts. You'll see these like millions and millions and millions of dollars. One point I want to make is that if a doctor is going to trial, unlike other things, if you hear a doctor is going to trial to defend themselves, they usually believe that they did a good job. That's like true malpractice is settled. Not all settlements are malpractice, but usually we're going to try to settle that out of court. Mm-hmm. The doctors that go to trial, and I, as a doctor who spent 12 years in one malpractice suit and went to trial twice defending it, again, a huge part of my career, I will tell you, it's this extraordinarily difficult, it's just a long and very, very arduous path. But we're seeing now, perhaps the doctor usually will win in those times, like 80 to 90% of the time. And the Pitt is, to my mind, one of the greatest things that happened to healthcare in years, because it tells the story of our competence. And that's a story that I want to see every single day, is a story about our competence, because by and large, we are very competent and we want to do the right thing. But shows like this, where you get to start a conversation even about it, to me, are just, they're just the beginning, and I hope we can keep the ball rolling.
This is great. This is great life advice.
I'm really glad. I'm really glad to have been here. I'm so excited and grateful to the writers that they're moving with the storyline. I can't wait to see what comes next. And thank you.
Awesome. Well, thank you so much. This was wonderful. I learned so much. I think the most interesting thing about talking to Dr. Gita Pensa was that there's not a lot of ways for patients to feel heard. And so sometimes taking it directly to a lawsuit, very extreme, is the way to feel like you've accomplished something, or that you've recouped something in some way, which is actually quite sad.
It's awful. And you have to feel for patients. We have a very, very frustrating, broken, fragmented healthcare system. Mm-hmm. And if something goes wrong, if there's an error, patients don't always know who the culprit is, but they're angry. Yeah. And inevitably there are law firms who will say hey, let's go sue this hospital. And then, like I mentioned earlier, there's situations where, yes, there should be an investigation. And I'm glad she brought that up. I'm glad she brought the emotions, and also the fact that some physicians feel truly scared and lost.
Alok, let's go back into the comment section. I'm feeling brave today. I'm feeling brave and curious. Let's see what people have to say again.
I want to read this comment because it deserves a slow clap around the world. I love the Pitt in your podcast. I wanted to be involved in the medical world, but because of my mild CP, cerebral palsy, I was limited to what I could do, and I just learned so much from watching you all. Bless your heart. I'm 70 now, but things like volunteering in food pantries, working on a suicide helpline, ringing bells for the Salvation Army, and working at a preschool for handicapped kids for 23 years. Who is this Nobel laureate?
I love that.
Amazing. What a well-hearted, amazing individual.
Yeah.
That deserved its shout out.
I do kind of want to see more volunteers on the Pitt. That's like a role that I
good
want to
call.
see.
Well, they have them show up in the Code Black, remember? The volunteers to go be runners.
Yes.
But you're right. They should have like more volunteers playing a pivotal role with patient care.
Yes.
Singing to them and stuff.
Yeah, I want to see like a volunteer like check Ogleby. Like in volunteer really school, like one of the med students. That could be cute.
Ogleby's not going to let it. Ogleby's too easy to be like, you're a volunteer. I have an ego.
Yeah, he's too busy reading James Baldwin to focus on people in his actual life.
Actually, I made a joke about volunteers singing. Music therapy would be a fun one to see. We have music therapists.
Okay.
That'd be a good one.
Yeah.
Or like one of the ERs I work at has a dog, like a service dog, who like rolls around. Service dog's name is Barker Posey. And like rolls around and like keeps patients calm. Like that would be, give me a service dog too.
My dog Remy is auditioning. Not a service dog, but she's a service to humanity.
That's it for today's episode of the Pitt Podcast. I cannot wait to talk about episode 11. Hope you'll join us. We'll be right here every Thursday after each new episode.
You can watch us on HBO Max or listen wherever you get your podcasts. And please leave us a comment, a question, or reflection, anything. We would love to hear from you. The Pitt Podcast is a production of HBO Max in collaboration with PRX. The executive producer of PRX is Jocelyn Gonzalez. Our managing producer is Courtney Florentine. Our editor is Lucy Perkins. Our production managers are Edwin Ochoa and Tony Carlson. Our video producer and editor is Anthony Q. Artis, with assistant editor Damon Durrell Hinson. This show is engineered by Tommy Bazarian. Special thanks to Joe Carlino.
The executive producer of HBO Podcasts is Michael Gluckstadt. The senior producer is Allison Cohen-Sirokach, and the associate producer is Aaron Kelly. Technical director is Insung Kwang. I'm Alok Patel.
And I'm Hunter Harris. We'll see you next week in the Pit.